for the time saving, I'd like this session. This session is a live case for complex PCI. Actually, this time was two live demonstration on National Taiwan University Hospital, two live cases. I am Hong, Severance Hospital. I'm my co-moderator, Dr. Lee, Mike Lee from United States. There is a famous panelist, Dr. Aramsareewong, and Dr. Chen, and James Flaherty, and Dr. Gerber, and Dr. Kang, Dr. Kwok, and Dr. Lee, and Dr. So, and Dr. Testa. Okay, the live demonstration from the Taiwan is ready. Dr. Kao, Professor Kao, can you hear us?
Yeah, we can hear you.
Okay, thank you for your live cases.
Okay.
Okay, please introduce your team and your cases.
Right. Okay. So welcome everyone to Taipei. We are now in NTUH. So we are very happy to be transmitting two interesting live cases to the TCTAP 2024. Yes. So today, me and my team, we have Dr. Ke, my first assistant, and also our fellows, Dr. Zhang and Dr. Guanwei, Dr. Lin. So today we have a very interesting case for you. It's not a CTO, but it's a very complex bifurcational calcified lesion. So I'll let Dr. Ke to introduce the case first to you.
Okay, please show me the slide. Our case today is an 85-year-old man, a patient with CAD, three-vessel disease lemon, and the patient had progressive dyspnea and chest pain in recent 1 month. He received salient scan, and salient scan shows severe ischemia at the circumflex territory and even LAD territory. The patient received coronary angiogram 1 month ago, which showed lemon with triple vessel disease. The syntax score was 63. We suggested patient cabbage, he refused, so we proceed to our PCI. Okay, next. The patient's demographic characteristics is below. I think the indication for intervention is stable angina with lemon and the severe ischemia. Next. As we can see, the patient's lesion, the lemon shaft and distal had 70% stenosis. The LD proximal and the mid had around 50% stenosis and was heavy calcified. And the circ ostium had even 95 and even 99% stenosis and also heavy calcified. The RCA is also diseased. The ostium had around 50% stenosis and also calcified. Next. And I think our target today is lemon bifurcation lesion. Our strategy is we will use a very comprehensive image evaluation, including OCT, and to evaluate the lemon lesion and LAD lesion to see whether something for debugging is necessary or not. And we consider using IVL for the patient's calcium management. And also we will evaluate the circumflex status to see whether bifurcation stenting is needed or not. Okay.
Yeah. So, well, I think one picture says 1,000 words. Why don't I just show you today our first diagnostic angiograms? It's a very complicated CAD, and also the patient had a mild aortic stenosis. Show us the
angiogram on screening.
Can we shift to the angiogram?
Yes, we did not see it.
Okay. Yeah. So these two are the first shots. This is 7 French EBU 35. So you can see the lemon shaft is narrowed with heavy calcification, extending into the LAD. And I'm sorry, And you can see the circumflex ostium is almost 99% stenosis with sluggish flow distally. And there is another segment of lesion with the eccentric calcification downstream. Next one. Yeah, if you look at the spider projection, you can appreciate the circumflex ostium more. So this is near occlusion with a lot of bending in the circumflex ostium. The left system is quite dominant, so his LAD is very long with a very large territory. So with an image like that, I would like to hear from you any treatment strategy for this patient.
So what is your treatment strategy for this patient initially?
Or should I let you see more with the OCT runs?
Yes, please.
How about the right coronary artery?
The right coronary artery is, the flow is good. There is about 70% narrowing at the proximal RCA. Also heavily calcified, but very short and discrete. So we think the RCA may need treatment afterwards, but today we did not take the RCA diagnostics.
Yeah, let's take a look at the intravascular
The left
imaging.
ventricular function is good. Okay, just let me quickly brief you what we have done. Okay, next one. So we send a wire into the LAD. We send a pressure wire down to the circumflex. Because I like to keep that pressure wire in the circumflex, I want to do a simple crossover, if I may. So I will treat and then leave the wire in the side branch to measure the parent vessel stenting result. If the side branch FFR is normal, after treatment, I will just keep the crossover stenting technique without putting second stent. So in the circumflex, there was a FFR wire, pressure wire, and the initial pressure was 0.46, as expected. Next one. And then we did a OCT run from the middle LAD to the left main. Can we show the OCT? OCT? Yeah. Dr. Huang, can you explain? We have Dr. Huang Qinchang as our IVAS imaging interpreter today.
This is the OCT pullback from mid-LAD. Let me show the OCT. This is the proximal part, it's the left main. And you can appreciate the severe calcification and very tight lumen size. And then here are left main bifurcation. We are going into the LAD. Let me show you manually. It is all the way diseased into the mid portion of the LAD. Let me show the calcification. This is the bifurcation. This dot indicates the position where the circumflex goes into the left main. And we can appreciate that at the distal left main, right proximal to the bifurcation, there is severe calcification. The calcium, the arc, is more than 270, and the thickness is more than 1. And we think this is the most critical part with heavy calcification. Regarding the more distal LAD, there's a short segment of calcified lesions with arc more than 270. But there is, the length is short, so we might not need to use a modification device. In terms of the size, the left main size is around It's around 4.0. The lumen is 3.9 or so, so we round up to 4.0. And the proximal LAD is around 3.5.
So basically, this run tells us that the left main bifurcation involving the distal left main is heavily calcified with very concentric calcium and the very thick calcium. So that spot, probably we need IVL to actually get rid of the calcium. But downstream LAD, even though it's diffusely narrowed, but we can do just fine with the balloon and stenting. The issue is the circumflex ostium. Okay, next. So we have done a 1.5 balloon into the circumflex ostium because the flow initially was so bad that the OCT expected to be poor. Next one. And this is the 1.5 ballooning. Next. And also we ballooned the more distal circumflex lesion as well. Next. 2.0 balloon. Next. So after this mild balloon modification, next one. Next one. We are able to put in OCT into the circumflex. Next one. So this is the OCT run from the distal circumflex all the way back into the left main. Can we review that run?
Please show the OCT.
Yeah, the OCT is on.
Okay, let's see. This is the left main as well. And this is the most calcified and critical part of the left main distal bifurcation. And here is the circumflex ostium. It is severely diseased. There's no significance of calcification, but it is very tight. More distally, it is all the way diseased, but not severely calcified. Except here, there's some calcification. It's around 250 or so degree in terms of the arc. The thickness is around less than 1. The length is not very long.
So the plan is that according to the image, including angiogram and also OCT, our conclusion is that we need IVL for the left main to LAD. But from the left main into the circumflex, maybe we just need a scoring or cutting system, and then to make a fine expansion without too much dissection. Because my plan is to have a DCB applied to the circumflex and a DES deployed from LAD to left main. With the final FFR, if it's okay, then we will leave the circumflex ostium with just a DCB.
I
That is
agree
my
with
strategy.
your treatment plan. Any other comment and question on these cases from the panel?
Yeah, why do you choose IVL instead of atherectomy?
Okay, for the LAD left main, because the remaining lumen is big enough, I don't think with a rotablator we can achieve too much lumen. And also after rotablation, you can see from the OCT, the original calcium is very thick, actually more than 1,000 micron. So even with the rotablation, my suspicion is that the remaining calcium is still too thick for a very good stent expansion. So I want to use IVL, so that we can have a better stent expansion.
Sometimes it can be tough to deliver in such a tight lesion.
Understood, yes.
Dr. Kao,
If
hi.
that's the case, maybe we need to expand the lumen a bit. But the left main to LAD, the angulation is relatively straight.
Yeah, it's
so
short.
my impression is that probably we can send the IVL balloon in.
Dr. Kao, hi, it's Michael Lee. What was your
Michael, yeah.
balloon size for the ostium of the circumflex? Was it a 2.5?
No, it was just a 2.0, just for bringing down my OCT catheter.
Got it.
And also a good flow.
What do you think about, well, first of all, what do you think the RVD is for the ostium of the circumflex? Was it about a 3.5 or 2.75?
Well, approximately just after the circumflex ostium, it's around 3.25.
3.25?
3.25, yeah.
My thought would be the following. Why not try pre-dilating with your a balloon that's the size of the RVD and look to see if there's any recoil, because if it does recoil, then it does suggest that even if you do a DCB, you may not get ideal results. So it's almost like a primer test.
Exactly. We need a proper dilatation. But instead of using a regular balloon, I like to use a scoring system or a cutting balloon so that I have more controlled dissection. And also, the odds of ending up with a necessary stent will be minimized.
And you have a buddy wire down the circumflex, so you've got 2 wires down there?
Yes,
Just
yes.
for-
So let's just review the next scene. After this understanding, we send another wire into that OM branch, leaving the FFR wire, pressure wire in the distal circumflex. Next one. And then this is our 275 NC balloon. So this is just to test the expansion of that distal circumflex. Next one. Next. And this is the cutting balloon that I have just mentioned. So this was a 325.
What do you think
Wolfram.
about the expansion?
Yeah, next one. You will see it was delivered very gradually at a relatively low pressure, so we did this very gently. Next one. Next. We make the balloon to make the curve gently and then inflate gradually.
Okay.
And this is the result where
Great.
we are right now. So the proximal circumflex had been cut with a 325 scoring balloon, cutting balloon actually. And then the distal circumflex had been expanded with the NC balloon,
You know,
275.
the LA Ocado view, the ostium still does not look great despite using a scoring balloon.
Yeah.
So
Yeah.
we'll see, but I just think that personally, maybe a two-stent strategy might be the preferred option.
Yeah, two-stent will be my bailout. But I mean, in this kind of true bifurcation, especially with that big circumflex angulation, a two-stent, I mean, the circumflex stent, the restenosis rate is going to be very high. Next. So we did another, actually the final OCT run from the OM branch to the left main. Can we review that? And then we will make decision on the next.
Can we see the OCT?
I don't think you have to stent the whole vessel, but you might have to stent the ostium of the circumflex.
I mean, the other thing I thought is you could do a culotte. I know this isn't done very often in this part of the world, but you know, where I'm from, we do a lot of culotte. And if you prepared that well and culotted it almost like a mini culotte, you would get a really good result, particularly if you put IVL in the circ as well. That would certainly deal with your osteal concerns. I think T-stent or a TAP here, I'd be worried about osteal restenosis, but a culotte would look good. You know, you just got to prepare it.
My favorite two-stent strategy is culotte as well. So, yeah, I agree. If I had to do two-stent, I would do culotte. But my hope is that I can keep this lesion simple with the one-stent crossover, and the circumflex just treated with the DCB. But then we have to see what the balloon expansion results are. Okay, can you tell us, Dr. Huang?
Yeah, let's see the circumflex ostium. So let's begin from the left main. We're approaching to the bifurcation, and you can see here is the circumflex ostium, right after the cutting balloon. And the lumen is still inadequate. It's just 1.8. As Michael suspected, there's significant recoil after cutting dilatation. Distally looks fine. So the problem is the circumflex ostium.
Yeah. So, like I said, my plan is to have a good cutting and the DCB result. But right now, the expansion of the circ ostium is not yet enough. Of course, we can go for a higher pressure. There was only a 325 warfarin cutting at 10 or 12. So let's have a 3.5 NC balloon, 3.5 by 15.
Paul?
Yes.
From Hong Kong, it seems from the OCT and from the ballooning, there's a ways, even though you're using a scoring balloon. It's from the OCT and from the fluoroscopy, from the limited fluoroscopy, it seems the anatomy of the ostium circumflex like some kinds of eccentric calcification, whereas you can always do a balloon dilatation under stent boost and then to confirm. Very likely the behavior for this particular anatomy is more like of a eccentric classification, and for that aspect, probably a provisional stenting may be a bit challenging once because of the angle together with the calcium, or already a lot of dissections. If you go to a belt out, the two-stent strategy, and then it will be a little bit more challenging.
Agree. Because according to any criteria, this is a very difficult bifurcation. So the chance of having two stents are actually high. So yes, you are right. We can start with the dedicated two-stent strategy here. But like I explained earlier, my hope is to be able to do a crossover stenting. With all these devices available right now, we have this luxury. So we can just continue intervention until the final result tells us whether this goal or strategy is possible or not. I mean, of course, I can do a two-strand strategy right now, put in a stent in the circumflex and then culotte the lemon LAD. But my hope is that if I can achieve a good result on the circumflex, I mean, good result, it means that the angiographic result probably not so beautiful. But as long as the FFR result is good, in our past experience, sometimes this is the best way. Because we can go with a two-stent and leave the patient with a perfect angiographic result, but then in 3-6 months, we will have a nasty circumflex osteorestenosis, which is very, very difficult to handle.
Yes, exactly, because this anatomy is prone to have recurrence. So
8.
you have the pressure Y inside the
14,
circumflex, right?
14,
So what is the reading of the
18.
pressure
18.
right now after you do some lesion preparation?
We did not check. We did not check it yet. The initial opening FFR for the circumflex distal was 0.46.
Yes.
Yeah, we can do that after this ballooning. Okay. Yeah, let's
now
go.
It's a,
Yeah.
it's a 325, right? It's a 3.5.
3.5. It's a 3.5.
Yeah, it's still there's a ways over there.
16,
16.
20.
20.
Okay, now it's 20. Yeah, I agree. From the
still the
circumflex,
waist.
I mean, from the spider view, there seems to be a waist still. But if this is the case, wouldn't you try to further expand the lesion before you put in a stent? Otherwise, you will have a full expanded stent right there, right? Okay,
Yeah,
20.
But you could try it. You could just use the IVL.
Yeah, there
and
was
the
some
LAD
calcium
and the
on it,
circ.
too.
Just use it twice.
Yeah, we can, of course, we can IVL both LAD and the circ. Yes. Okay,
Yeah.
right.
Personally,
So
I think
let's-
it's this kind of case is the initially planned to the two-stent technique than the crossover technique. The reason why, first one is the severity of the calcium is very severe, and second one is the angulation
OCT.
of the ostium of circ is the hyperangulated. So when some serious event like the sudden acute loss of the circum is the recannulation is some difficulty. So personally, I initially planned to the two-stent technique.
Agree. Okay. Anyway, we have done a high pressure balloon here. We can see some waste. So let's check OCT, and then maybe we have a FFR pressure reading on the circumflex, and then see if the result will surprise us. So you see the distal calcified lesion also is very nasty. We should treat the distal circumflex as a separate lesion. I mean, okay. Okay, yeah. Okay, so we're ready for OCT. Let's flush the lumen. Okay. Yeah. Okay. Can we run? Okay, let's take a look at the result. Obviously, the distal circumflex lesion needs to be stented.
Can I
But
play
the
devil's
point of
advocate,
interest is-
Dr. Kao?
Yes?
This is an 85-year-old male
Yeah.
where he has distal left main disease. In the grand scheme of things, treating the distal circ versus just, because he's not going to have a mortality benefit from that, but he will have a mortality benefit from just a distal left main.
Right,
And just leave
right.
it, keep it simple. That's just a consideration.
Right.
In the OCT examination, we already found that there is a lot of the calcium in the lesion. So the next the examination, we want to know about the sizing of the vessel, and rather than the severity of the calcium.
I think despite my wish to have just one stent, I think my feeling, reviewing all this process, I think we will end up with two stents in the left main bifurcation. So I think it will be a culotte configuration, but before that, we will do IVL on both. The distal circumflex, I will also stent as well in this one session. So let's just review the OCT, and probably we can send you over to the other room because Dr. Chen had also a very interesting case for you. Okay. And I think so far I have given up on my hope to have one stent crossover strategy. Probably now we'll have to do a two-stent culotte configuration.
Okay, good luck.
Okay, let's see
look,
the
I
OCT before
agree.
we leave you. Can you review the OCT, please?
Okay, let's see. This is the left man. We are approaching the distal bifurcation here. And then this is the circumflex ostium. here. As you may see, the lumen size is still inadequate, even less than 2 millimeters square.
Okay, 넘버 IBM 주제.
So I think standing is inevitable.
Yeah. Okay. So despite our struggle and try, I think we will end up with 2 stand. So it will be just a usual culotte configuration. Okay.
Right.
So thank you for your patience. And despite my hope to have 1 stand, but probably we will end up with 2 stand. Okay.
Okay, let's move to the another lab. Okay, Dr. Chen, Ying-Hsien,
Oh,
Chen.
yes.
Okay, thank you for your live cases. Okay, please introduce your team and the cases.
Okay, sure. I'm Dr. Chen, and before introducing our case, I would like to introduce my member here. Dr. Ye Zifan is our second operator, and we have young fellow Dr. Lin and Dr. Zhao as well. And Dr. Ye will going to introduce the case for you. Dr. Ye, please.
Good afternoon, ladies and gentlemen. I'm going to introduce our case. This is a 63 years old gentleman. He has a history of the inferior STEMI in 2018, but he lost follow-up for the total revascularization. And he developed 2 episodes of heart failure in 2024, including in this January and March. Next slide, please. So his background, he had diabetes, hypertension, hyperlipidemia, and he also is a current smoker. His creatinine is normal, but he had a stable angina with the decompensated heart failure. Next slide, please. So previously, we have the echo which showed the severe reduced ejection fraction with the LV ejection fraction 23.7% and with severe TR. And for the further treatment, we have a full discussion with him, and he declined the CABG option. So the previous CT scan showed a bilateral iliac artery diameter is over 6 millimeter. Before this episode, he had undergone 1 intervention in other hospital which showed the left main bifurcation lesion, including proximal and LOD and proximal circumflex lesion. Next slide, please. So today, our target is the proximal LAD and proximal circumflex with the bifurcation stenting. The plan is using the IVUS as well as the mechanical circulatory support. Next slide, please. So this is the briefing of this case. Is we introduced the bifurcation stenting, and because this is complex and high-risk intervention, so we use the hemodynamic support in this case.
Okay, thanks, Dr. Ye. And I would like to add some information about the history. And as you have seen that the description of coronary angiogram that we are going to introduce to you later. And it was the report previously, but the patient was still an active smoker. So definitely you will see the progression of the coronary artery disease at this time. And initially we planned to treat the Medina 011 left main bifurcation lesion because the lesion really located at proximal LAD and the ostium of the circumflex. But this time the disease progressed severely, and the symptom also developed into the acute decompensated heart failure. And for the left ejection fraction, initially it was 50% after sustaining the first episode of acute myocardial infarction, but this time it was only 23%. So and maybe we can add some information about the coronary angiogram and discuss about the treatment plan later. Okay, please show the coronary angiogram. This is the right coronary angiogram. The previous stent was implanted at the mid-RCA, and the PLA, we can observe some lesion there. Okay, next. Okay. This is the left coronary angiogram. Was seeing the progression of the left main this time, and diffuse lesion distally next, including the distal mid portion of LAD and the distally circumflex. Okay, next. Okay, with the tortuous circumflex and also disease in the LAD ostium proximally and the mid portion. So this time we are seeing not only osteal lesion, but also involved a little bit deeper from the mid portion of LAD and the distal circumflex. So we prepared this case and this time, and we have some thoughts about our treatment plan, and I would like to welcome all the suggestions for this patient's treatment. Thanks.
Okay,
Well, thank you for this introduction. I would like to ask one thing, because I've seen from the plan of this procedure that you are about to place a LiveVac system to leaders instead of an Impella. Is that because Impella is not available, or there are some other reasons? Especially because with Impella you can use just one introducer in the femoral artery, so you don't need two accesses. With the IVAC, you need two accesses. So, is there any specific reason about that?
Okay. In Taiwan, Impella is available also, and as well as the IVAC. And the patient has a good peripheral vessel. We had evaluated with the CT examination. And they maybe as well that all the experts were really familiar with the Impella system, Impella CP. So this time we trying to try something new with you, and we select IVAC this time.
What is the LVEDP? Left ventricular and diastolic pressure.
Sure. Before any procedure, we had complete hemodynamic study. The LVEDP was 29.
29?
29, yes.
Okay, I'm not very familiar with this MCS. Is it basically an ECMO system?
Well, basically, it's also a ventricular assist device because it draws the blood from the ventricle and propels the blood into the aorta with different mechanism. And we call it the IVAC2 because it generates about 2 liters of the cardiac output per minute.
Okay, so it does unload the left ventricle?
Yes.
Okay,
yes.
great. Do we have any data, like with Protect 2 and Impella, there is benefit at 90 days per protocol? Is there any data?
I don't believe there is any head-to-head comparison, but of course there's definitely case series showing the effect of the IVAC system.
And you said also left main bifurcation within a class 011, but I think left main osteal lesion is also very severe, and so be careful about
that's
the
what
left
I
main.
said.
Yeah, it looks very small. It's probably a 111.
Did you do a viability study to see if there's any recoverability, or you did not do any viability study?
Viability study.
Okay. Because the patient was really has depressed LVEF, so any stress was not suitable for this patient. And we carefully review the history that the patient denied any episode of acute myocardial infarction. Any episode. He denied any angina acute chest pain before during this time. And from the ECG, there is not much Q wave expect for the previous inferior Q wave. So although we didn't have viability test, the patient was really in the low LVEF state. Okay. And we do not perform the myocardial perfusion image this time. And I think it's maybe risky in this kind of low EF to perform the stress test.
It was no viability study. I mean, you don't have to do a stress test. Is the LV dilated?
Yeah, yes.
I mean, one would question whether, even if you do successfully revascularize him, whether he will get any meaningful recovery. And if it's not likely, then perhaps evaluate it for advanced therapies.
Yeah, what's the suggestion for all the audience or the panelists about this treatment strategy for the left bifurcation in this case, according to the angel?
I think for some patient like this, always getting more insights of the viability can be helpful. But from very basic investigation, like for example, we are taking the left side, but it is not a CTO. It's a patent artery, although the flow to the circumflex is a little bit jeopardized. From the very basic information like the EKG and echocardiogram, sometimes we will get insights of whether the patient, the myocardium is non-viable or not, like, for example, frank Q wave over the anterior leads, chest leads, or you have a very thin LED thin myocardial wall over the target territory. Then we may think twice whether to put the patient to have these sorts of high-risk procedures. And whereas if a patient with you don't have that features, and most of the scenario when we think that we're able to help the patient by revasculating them. Of course, in nowadays we have lots of controversy clinical data from the recent trial, including this revised breakthrough trial, which always these kinds of decompensated heart failure patient, optimal guideline diuretic therapy is the key before we contemplating revascularization. But I think it's still debatable, but I think it's still worthwhile the patient to revascularize that patient as far as from those preliminary clinical information is not subjective for very infarct territory.
Okay, Dr. Chen, for the time saving, okay, go ahead. You're the
okay. Before any procedure, we begin with the IVEC placement, and I'm going to show how we have done right now. Okay, next. Okay, also similarly using 18 French sheaths, and we deliver the sheaths. Okay, next. And we use a pigtail to locate the aortic valve. And you show we had a hemodynamic study with a PA catheter. Okay, next. Okay, we first place a pigtail was quite similar procedure. Next, and using a super stiff wire. Okay, next. So now we place the so-called IVEC 2, and it suggests with a 2 to 3 centimeter into the ventricle, and this is how we place the IVEC 2 catheter. Next. Okay, we can need to pump, and as you probably know, that the IVEC was connected with the IABP machine. So using the IABP pumping, it generates about 30 to 40 millimeter of the blood flow each beat, and so probably 2 liters per minute of cardiac output. Next. Okay, and we're going to perform the procedure, and during the IVEC support, and initially the PA pressure systole about 40, and with the IVEC support, the PA pressure declined to probably 35 right now, and the wedge pressure was a little bit lower, and but it's still about 20 right now. And with the IVEC support, the blood pressure indeed improved a little bit, and we're going to perform the procedure. And initially, we placed the wire to LAD distally and to circumflex distally, and the lesion was progressed. It's difficult to negotiate the lesion. Okay, next. Okay, next. LAD was more easier, but the circumflex, there's some critical lesion. As you may have seen, the wire tip was located, was stopped here. So we're using another wire, and next. And the wire can pass through the critical lesion with a microcatheter support. Next. Okay, now we place 2 wires in LAD and circumflex, and we probably perform 2 balloon angioplasty to improve the blood flow, but still this doesn't improve too much. Next. So this is how we, this is immediate after wiring. Next. Okay, this is a 2 balloon. Next. Okay, next. Next. And we also, we try to IVUS LAD first, but the IVUS just can't pass. So we also perform the balloon angioplasty LAD as well. Next. Okay, next. There's some critical point here. Next. Next. Okay, next. Okay. So then we place IVUS into the LAD to have the image information and also to circumflex. So maybe Dr. Huang will help us through the IVUS right now.
Will we see the IVUS?
Okay, next. I'm showing IVUS. Okay.
This is the pullback from proximal LAD. As you may see, it is severely diseased, right, starting from the proximal LAD with some calcification. Let me going forward. Here the vessel size is around 3.0. As we are approaching to the left main bifurcation, the LD proximal part is severely diseased, is very critical. The calcification itself is not very, very severe. There's no napkin ring of calcification. Here we see the circumflex guide wire coming into the screen. So this is a distal left main. As we have seen on the angiogram, the LAD ostium itself is severely diseased. And the minimum lumen area is around 3.58 millimeters squared, which is definitely inadequate. Then we also IVUS the circumflex. This is also from the proximal circumflex. Let's see the circumflex ostium. The circumflex itself is severely diseased with some calcification. It's very, very tight right after the ostium. And here comes the LAD wire. This is the circumflex ostium. So the osteo, circumflex, LAD, and left main are all severely diseased.
Okay, thanks, Dr. Huang. And then maybe I'm going to show you the final, currently the final angiogram that we have right now. 最后一组，好，最后一组。So after that, we also 最后一组 ，OK， 最后一组，好。The final shot, please. And we also add on a 2.5 balloon. I think this is the result after 2.5 balloon. And of course, we're seeing dissection and disease distally, especially in circumflex. So I would like to your opinion from the panel and moderator to see whether we need to put all the stent distally or just we fix the proximal main bifurcation. Thanks.
You know, I don't see the diagonals very well. If it's possible to go maybe more of a steep AP cranial, like 40 cranial AP, just because there's diags, and I just don't get a good sense of where the diags come off and how they are.
Maybe the previous angiogram. Maybe a cranial view. 前一组. Okay, maybe I'm going to show you some cranial view here.
A steep cranial, like 40.
Okay, maybe we.
It's hard to see where a landing zone is going to be.
Okay. This is what we right now.
Okay, good.
Okay.
I mean, one option would be not to put too many stents in here because he's a diabetic who smokes, and maybe just stent the LAD into the left main and DCB the circ. Just because my concern is the more stents you put in this guy, you know, he's smoking and diabetic and calcified, they're all going to reach to nose. So you want to minimize that maybe, and you could always bring him back for surveillance, angio, you know, say 6 months, and I do that, and the vessels may grow. DCB might be an option.
there is also, hello? I think there is also another consideration we should make. I mean, if you look at the blush of this artery, especially the LAD looks really scleric. So in other words, it's not obviously a confirmation, but at least a signal that probably that wall is gonna be dead. So in other words, I will not spend a lot of stents there. I totally agree with this, let's say, keep it simple strategy. If we just put a stent, left main, LAD, and then we try to save another additional stent to the circumflex, we probably do the job for this patient, because honestly, I'm not sure that this wall will recover. So instead of taking the risk of long-term problems according to stent failure, we'll probably just put one stent. Well, according to the IVUS, all the post-dilatation that we need to do, I will optimize the stent to the left main, and that's it. Honestly, I will try to keep as much as possible the easiest procedure, the fastest procedure.
Yeah, one long stent, I agree.
Probably related to that, from the IVUS, we could see that the reference diameter was really small in the distal parts of the LAD and circ, which also relates to probably this muscle might not have viability, which was also discussed in the previous comments.
Prognostically, the left main LAD is more important, and make it simple. And probably a lot of the myocardium is already fibrotic, so fix the left main LAD. I think the circumflex is diffusely diseased. No matter what you do, you can't get good results anyway.
Yeah, I totally agree. In my plan, I just try to keep it simple. Initially, I would, my plan is to put a stent to fix the main LAD and circumflex as well. But since we only fix the proximal part, the distally was really diseased, so it doesn't make too much difference if we put a stent into the main circumflex. Just put a lot of metal in the main. So I agree that maybe we this time we just do a provisional procedure. We put the main into the LAD, maybe the proximal part. From angiogram, just proximal to the diagonal, just make it a simple procedure.
I think these two cases illustrate very similar anatomy, but a very different approach. With the first case, original plan for provisional stenting in the pause case, but this particular case, because of the uncertain viability, as well as the circumflex very diffuse small vessels, together with lots of side branch, with high OM branch, together with proximal D1. So putting a lot of metal, gelling a lot of side branch, together with the doubtful drug compliance, it's all makes, I think, our thinking of just keep it simple may be the best strategy for this patient.
I mean, my concern, honestly, is the fact this gentleman continues to smoke. He has diabetes. That combination with stents is lethal. You get stent thrombosis the moment you stop your DAPT. You know, I just keep him on DAPT. If someone's smoking and they're diabetic, they take antiplatelet forever. In fact, I sometimes even add in a DOAC small dose, because they just thrombose, particularly in the left main.
From the echo study, he have severe tricuspid regurgitation, which is not very common for the LAD lesion or left main. I'm not sure that the ejection fraction 20% is come from the LAD baby. It might be not ischemic cardiomyopathy, but some part of left main and some part of chori is affected, but I'm not sure about the severe tricuspid regurgitation. Maybe he have a non-ischemic cardiomyopathy.
He's probably got COPD, hasn't he, with lung pathology from smoking, so...
Yeah, let him know the panel thinks he should stop smoking. It's consensus.
Yeah, totally agree.
Okay, shall we proceed forward with the intervention?
Sure. Yeah, so maybe we just try to put a stent from the LAD to the left main. OK， 给我一个Sierra 哈3.533。I would like to put a 3.5 stent, because it's suitable to expand further in the main to greater than 4. I'm going to put a science stent.
What is the approximate LED measure on IVUS? I thought it was only 3.
You mean that we need to measure the diameter again?
No. What did it measure at
What's
the
the
landing
measurements
zone?
for the...
Okay, Dr. Huang, please.
In terms of the lumen size of the relatively healthy part of the proximal LED, the diameter is around 3.0.
That would be my guide for the stent size.
What about the estimated stent length or distal landmark? Where do you think that it will land?
It's diffusely diseased, so there are a few options. 24 is a possibility. Or if you want to cover more plaques, a stent longer than 30 is also reasonable.
Okay, 三零恩熙。Okay. So we need to dilate the lesion further. The stent just can't pass. I'm going to use a 3.0 balloon.
I'd like to ask Dr. Michael Lee, how would you treat these patients in the U.S. if it is a surgical turn down? Would you just medical therapy, do a viability study, CMR, or go ahead with MCS and high-risk PCI?
I would have done a viability study just to see the degree of recovery. If there's no viable myocardium, then I would evaluate him for advanced therapies, perhaps an OHT. If he's still smoking, he's not a candidate for OHT. If he has severe diabetes, he's not going to be a great candidate for OHT. If he's not a candidate, I would revascularize and maybe just address the life-threatening issue, which is the prox LAD left main. What I would do is after you address the prox LAD left main, I'd give some nitro, see how it lights up. I actually would do an FFR just to see what burden of ischemia is there. If there's a high burden of ischemia and the FFR is low, perhaps I would do maybe a DCB distally. I wouldn't stent the whole thing. I would want to see the runoff. If the runoff is poor, it's still ratty disease, maybe a small diameter DCB would be helpful. And I would keep the procedure simple.
Yeah, I agree. We would do what they're doing, one stent, and then try to get him on medical therapy for his heart failure. And
I think you might need a guideliner or one of the guide extension catheters.
address some of the other risk factors.
You know, delivering that's going to be really tough.
Yes.
Did you use a 3.0 NC balloon to predilate, or what did you use to predilate the proximal LAD in left main?
I just took a 3.0.
3.0.
Was that a compliant balloon or a non-compliant balloon?
Non-compliant balloon.
Okay, maybe go back with the 3.0 again and make sure it's going to be easier to deliver, because the inability to deliver a stent is probably suggestive or indicative of not optimal predilatation.
But I also think, Michael, there's a lot of dissection in that vessel and maybe getting caught up in dissection flap.
Yeah, we're seeing more dissection here. And with IVEX support, the hemodynamic is quite stable right now. Okay. So if we perform further balloon angioplasty, I think the dissection might progress further distally.
So if you've got a 5 French guideliner on the shelf, you can pass that with 2 wires.
I understand.
And that saves you having to possibly further balloon, which again could extend the dissection if you're concerned about that.
You know, with the left main disease, the other option would be to put a buddy wire into the LAD, just because when you start advancing guideliners with left main disease, with questionable myocardial reserve, so maybe just try conservative.
Yeah, or you could IVL that one segment. It looks fairly calcified where it was getting stuck. I don't recall what the IVUS showed, but there's a chunk of calcium there at the Distal left main.
The flow's looking a lot nicer though, isn't it? I think that's a nice thing to see, that the more work you're doing, the LAD's picking up and you're seeing more blush distally.
You know, this device is 18 French. I would have probably used an Impella CP, 14 French, get about 3.5 liters of support, but it looks like the patient's tolerating it pretty well.
What does this device cost? The cost may be a consideration. Cost may be a consideration. Impella is very expensive.
12. Go. 12. 18.
18.
Down.
How much is an Impella in the US?
So maybe
30,000.
have the balloon go neutral. Sometimes having the balloon go neutral and to see if you can advance it would give you kind of an idea of whether the balloon crossing profile is suggestive of a.
But the health system
stent.
pays a lot reimbursement for it.
Yeah, so I work in Australia and actually we're struggling with getting use of Impella.
It's
because of,
profitable in the U.S. because the way they've gotten Medicare to reimburse it at a very high rate, which other countries have not fallen for.
It's coming actually in Australia. Medicare is going to give it a nod, I think.
Has anybody tried asking the patient to take a deep breath in or cough? Sometimes that can help deliver a stent when it's difficult.
One of my partners has all his patients cough throughout the whole angioplasty.
I'm sure he can. I'm sure he can
It
cough.
mobilizes the heart.
It helps with the angles and things.
Maybe LAO cranial 30, 45.
You mean just to see that they don't miss the os?
That's us, yeah.
Well, I think the position is fine for me.
Yeah, it looks good to me as
Yeah,
well.
Okay.
BB's right in the sinus.
2, 4, 6, 8.
10.
10.
Down.
Down.
We're gonna dilate further, proximally. Okay, 18.
18.
Okay, down.
Still a bit constrained there.
I think this case actually also illustrates the diversity of the wide range of MCS around the world. So impellers, of course, is also available in some parts of Asia, like in Hong Kong, but may not be available in all. And also the cost is a major issue, right? In particular, it's much more expensive than the US, according to my knowledge.
Yes.
Yeah. If you totally can enlighten us, probably the US is cost less than in other parts of Asia. And also, of course, the good side is for this kind of case, you can, if the patient decompensate during the procedure, you can leave in the MCS for you to gain more further support.
There you go.
Whereas for the post-cat IVAC, of course, it did provide a very reasonable forward flow, but usually you can't really stay long inside the patient, and it's not intended for you for prolonged support.
Maybe give some nitroglycerin.
Can you leave this IVAC device overnight, or you have to remove it after the procedure? Because if you leave it overnight, that's risk of migration or perforation. You can see from the movement of the catheter. Is it safe to leave it overnight?
I think suppose during the IFU of this device is not intended for you to have a prolonged support. Usually, it doesn't really recommend you to have prolonged support. Usually within 24 hours at most. So it's not really dedicated for a prolonged MCS support as compared to the impeller family.
Can you show us the IVUS image? There you go.
I think it depends on what happens in the case. If he was unstable or very hypertensive throughout, I might leave it in. But if there was no hiccups, I would try to take it out.
The distal edge is clean, the spines are well expanded, but here I think it's underexpanded, need more post-dilatation. Then we are approaching the left main ostium. Okay, here's the position. The left main ostium is well covered by the stent.
Yeah, let's review the last angiogram. So we put a stent, lemon LED, and the circumflex floor was still there. The ostium was circumflex. We can see some haziness, and we are going to fix the stent first to well dilate the narrow part that Dr. Huang just mentioned, and to see how circumflex goes. Any suggestions from the panel?
I think that this is a very interesting and educational cases for the general practice. This is a really high risk and complex cases, but the procedure itself is simple based on the result from the IVUS examination. So fix it, just a single stent. It's a main message of it. And then second one is the IVUS run, there is something abnormal, and at that point we will selectively fix it, and then that is the main message of this kind of patient.
Would you rewire the circumflex first before you modify that?
I think I'm fully satisfied of the current result, because if there is some flow compromise in the circumflex, we will try to fix it. But you see in the circumflow is a TIMI-3 flow.
Yeah, I would pull the circ wire and just post-dilate the stent.
Yeah, I'd put the proximal optimize the left main just before the circ, and then
it's fully opposed on the IVUS.
I still probably would, you know. It opens up the side struts.
Yeah, if you want to rewire.
Because I would think I probably would treat the circ, if I'm honest, because it's been ballooned, and part of me feels like you should put DCB there. But
it's kind of a ratty.
18.
That's just my thoughts.
18.
What wire is in the
now
circ?
we have the 9 minutes the time left. We want to see the final result from the Dr. Kao's procedure.
Okay. Okay.
Dr. Kao,
Hi, Dr.
what's
Huang.
going on?
Yeah, according to your advice, we have done a culotte. We are at the final stage of kissing balloon and KVT. So let's review the angio, please. So we left you with the cutting and high pressure, but still suboptimal circumflex osteo result. So next. And then we did IVL. So this is the repetitive IVL. We have run 40 shots at the circumflex ostium. Next one. And this was actually a 4-0 IVL because we sized to the left main. Okay, next. So you see after 40 shots, the balloon is opened quite nicely, and this is the IVL result. Next. And then we apply the same IVL balloon on the left main LAD as well. But you see this one opens up quite nicely, much better than the circumflex. Next. So actually we have used 20 shots on the left main LAD. So actually the balloon had another 20 shots. Probably offline we will work on the RCA with the same IVL balloon. Next one. And we did the IVUS run, OCT run, which I will now show you. But anyway, this is just for the define the choice of our stents. Next one. Next as well, the circumflex. Okay. So we decided to put in a Onyx 30 by 26, yes, for the distal circumflex. Next one. Deployed. Next one. Result. Next one. And then a 3.5 by 15 Onyx from left main to circumflex as well. Okay, next one. This is the actual deployed position. Next one. Deployed. Next. Proximal pot. Next one, using the same stem balloon. And this is a 2.5 balloon to dilate the side branch, the side hole. Next one. After wire switch, of course. And this is to change projection and then decide our stent length for the LAD. Next one. So the LAD was a 3.5 by 38. Next. And this is our stent position. So actually we leave the proximal part of the left main alone because the vessel is very big there and there's no point of putting a stent next in such a large disease-free left main. Next. Next. So this is the stent deployed. Next. Again, stent balloon part. Next. And we switch the wire. This is the result. So we are at the point of sending both balloons inside for the KBT.
So far, very excellent result.
May I ask, has anyone done a KBT with 2 lithotripsy balloons on the panel?
Okay, another one.
Do you know if anyone's put 2?
Yeah, it's actually very helpful. And what I've used it in is when the left main is, let's say, a 5 millimeter diameter, 4 millimeters of largest size. So when you do simultaneous kissing IVLs, you can approximate a 5 millimeter.
Yeah, because it would have been a brilliant option here, right?
Yeah.
But you need 2 generators, I guess, and.
Yeah, you need 2 generators and 2 catheters, so it's very expensive.
Yeah.
But you
And
could
also,
take,
I think
you could take
the
another
balloon-
balloon and just swap them.
Just.
Where 2
Yeah, but the question
IVL
is whether
balloons
you-
are
whether you get
contacting each
synergy,
other, I don't
you
know
know,
what
like-
happened in that interface.
Because
Okay, let's
maybe
go.
the acoustic
10,
wave is actually bigger. It's like
Both.
2 waves coming,
Go. 16. Okay, so both are 3.5 and 16. 1, 2, 3, off. Okay.
And they're
One more
NC balloons?
proximal. Yeah, NC, these 2, of course. And give me a 5.0 NC short one so that I can do a final part. Okay, go. 8, 10, 12, 16. Okay, 1, 2, 3, off. Good. Okay, so we have done our KBT. I don't know if we have time to show you a final OCT run on this.
We have 4 minutes, 3 minutes, just to show us the final angiogram.
Sure.
We want to move to the final result of the another.
Sure, okay. Well, I will just show you right now before we did our part. The part is an easy part. Okay, so that's going to be our semi-final result.
Okay.
That's beautiful.
Okay?
Okay, very good.
Okay, thank
Really
you guys
appreciate
for your patience.
contribution.
Thank you.
Great job.
Okay.
Thank you. Thank you.
Let's move to another room. Dr. Chen's cases. Okay, please show us your result.
Okay. Okay, let's see the previous angiogram. The last one. So we perform the part, and we take out the circumflex wire, and this is the angiogram. And let's show the IVUS. Okay. IVUS, please. Okay, IVUS here. So the same, the distal landing of the stent was good. The expansion is fine. Yeah, Dr. Huang is there. Okay.
And let's move forward. I think this is the most underexpanded part around here as well. The proximal part is good, so let's see.
I believe this slight improvement.
Yeah, it's improved, but I think it's still inadequate.
I think there's the minimal stent area is quite acceptable.
Yeah. Maybe we can try to optimize this part. And I think we're done with this bifurcation procedure from the angiogram. Let's show the angiogram. The circumflex flow was good from the lateral projection. So maybe we are going to focus on the narrow part of the stent and optimize the stent result.
Even though the osteoma of the circle is quite severely narrowed, but the TME free flow, I like that so far is good. If you want to fix it at the circle and then touch it, I think it makes us a new complication.
Yeah.
Okay. I think the final result is excellent. Congratulations. And this case is a real educational case.
Well done.
Thank you for your contribution.
Okay, thanks.
Okay, I'd like to close this session. Thank you all panelists and the cases.